Good afternoon, everyone. I hope everyone's doing great. My name is Camilo. I'm part of a collaboration between the World Federation of Pediatric Imaging and the ISMRM study group in pediatrics to foster education and collaboration across scientists and physicians all across the world. I work in this endeavor with Mary Louise Greer and Mike G, who are coming in. And we've today organized a webinar for you guys with a different flavor from the one we did before. And we have an outstanding slate of panelists and speakers that are going to cover a number of talks and topics that I think will be of use to all of you. Just a quick set of reminders. This webinar is being recorded. It will be posted in the next couple of days to the websites of both the ISMRM and the WFPI. Also, to facilitate all attendees following in conversations around educational subjects, if you have questions or comments, please set your chat box to everyone so that all of the attendees can benefit from these. The title of this webinar is Mimics and Pitfalls in Body and Musculoskeletal Imaging. We have two terrific moderators. There are Sikandar Shaikh and Lisa Suzuki. As I just mentioned, this webinar is part of this global collaboration in MRI that's meant to facilitate knowledge and dissemination. Following on the third webinar that focused on artifacts and mimics on neuroradiology, this fourth webinar will be looking at technical factors and pathology in the lung, body, and musculoskeletal system, including prenatally diagnosed, which can contribute to diagnostic challenges. Our speakers are physicians and scientists from both organizations, and they will share examples of how to problem-solve dilemmas encountered day-to-day and in the acquisition of these cases. Without any further ado, I'll let you with our moderators, Dr. Lisa Suzuki and Dr. Sikandar Shaikh. Sikandar, you're muted.
Good morning to all of you who are joined today from US, Canada, and North American countries. So it's a great pleasure for me to invite you all for this exciting collaborative webinar of ISMRM and WFPI Society. So we have a blend of speakers. So without taking much time, I would like to introduce the first speaker, Dr. Brandon Zaneth from the Hospital for Sick Children, Toronto, Canada. So he will be speaking on pediatric lung MRI challenges and recent advances. And I request any attendees to please post your questions in the chat box so that end of this session, we'll take the questions. And if time is permissible, then we can take all questions. Otherwise, we'll take only relevant questions. So with this, welcome, Brandon, and over to you.
Thanks for that introduction. I just wanted to make sure everyone can see my slides and can hear me.
Yes, we can see your slide. Yeah,
great.
Perfect.
Okay, with that nod, I'll begin. Thank you for the introduction, and thanks to the organizers for inviting me to speak today. As part of my disclosures, I'm disclosing that I received partial salary support from Siemens Healthineers. But getting right into it, lung MRI, as some of you may know, is traditionally very challenging and suffers from several limitations related to both basic physics considerations, as well as motion and subject compliance. And as a result, really, lung MRI has historically seen very limited clinical utility. Now, despite this, MRI has some obvious attractive benefits that may benefit pulmonary imaging in children, such as lack of ionizing radiation, the ability to leverage multiple contrasts, and the ability to probe both lung anatomy as well as function. And recent advances in sequence design, as well as associated acceleration and reconstruction techniques in order to decrease scan durations, thereby possibly improving tolerability, may assist in further clinical translation and more widespread adoption. But to discuss some of the major pitfalls that have challenged us historically, one of the major pitfalls and challenges in lung MRI is due to the nature of the organ itself. The lungs are a significantly aerated organ, and as a result, the tissue density of the lung parenchyma is only around 20% or so by volume, yielding low intrinsic MRI signal intensities in the lung. Furthermore, the numerous air tissue interfaces in the terminal airways of the lung, as can be seen from this micrograph, lead to very high magnetic susceptibility variations in the lungs, which are obviously detrimental to signal coherence. And as a result, the T2 star in the lungs is very, very short at clinical field strengths, around a millisecond or so. And together, these cause what little signal is present to decay away very rapidly, leading to low overall signal intensities and poor image quality with conventional imaging sequences and conventional echo times. Additionally, one of the largest barriers to implementation, of course, is motion corruption and subject compliance. Lung MRI is very susceptible to motion corruption from a variety of sources associated with respiration, cardiac motion, but especially bulk patient motion, which is a particular concern in pediatrics, as younger patients may not be able to tolerate long periods of stillness typically needed for pulmonary MRI, or be frightened by the MRI and possibly necessitate sedation. You can see on the screen here various examples of some severe patient motion corruption. On the left are two different 6-year-old subjects showing severe motion corruption on these axial T1 weighted scans. On the right is another example in a neonate. The top set of panels is a set of coronal slices from a T2 weighted fast spin echo scan, and the bottom is another axial T1 weighted scan in this same baby. So you can see here that the major pitfall for motion in these cases is this basically a complete loss of diagnostic image quality and significant artifacting of other parts of the anatomy into the thoracic or chest region. To improve tolerability, educational dissemination may be disseminated to parents. Distraction methods such as MR-compatible audiovisual systems for movie watching or music listening may also help, or acclimation strategies such as child-friendly imagery, mock MRI systems may all benefit tolerability and improve quiescence for MRI. However, assuming you have a compliant patient, of course, one of the easiest ways to remove respiratory motion is with a coached breath hold maneuver during scanning, which is relatively common. And some examples of breath hold scans are shown here. However, you can see that you still sometimes get motion corruption from cardiac motion during the cardiac cycle, which can enter into the rest of the thoracic anatomy, obscuring lung anatomy in the case of some ghosting in this axial scan, or some partial voluming in this coronal scan as the the heart beats in and out of frame. Furthermore, being solely reliant on the ability of patients to hold their breath, even if they have good tolerability, breath hold durations are short, and they limit the achievable resolution and image quality we can get due to time constraints. Furthermore, breath holds can be challenging in younger subjects, and of course, for infants and neonates, coached breath holds are completely out of the question entirely. One way to mitigate some of these issues is to use motion robust acquisitions. One example I've shown here is the propeller or blade or multi-vane sequence, depending on your vendor of choice, which acquires these parallel lines in K-space that are then rotated to cover all of K-space, heavily oversampling the center here, where most of the contrast and low spatial frequency information that isn't changing much in time reside, allowing us to compensate for some motion. And on the right here is an example of a T2 weighted blade acquired at our institution in a free breathing, non-sedated 5-week-old infant. And you can see that cardiorespiratory motion from both breathing and the cardiac cycle are reasonably well suppressed here. Of course, other strategies that are used to compensate for respiratory motion typically involve some sort of physiological tracking of a subject's respiratory waveform, in order to either trigger an acquisition to start collecting data during a predetermined portion of the respiratory waveform, such as at end inspiration or end expiration of normal tidal breathing. But alternatively, imaging data may be constantly collected, or what we call gated, during free breathing, and physiological data is concurrently recorded alongside during the respiratory cycle in order to retrospectively bin portions of the acquisition together to create a motion frozen set of data. One example of how to do this is on the screen here with respiratory bellows, which are basically a pressure transducer that wraps around the patient's thorax and can detect the expansion and contraction of the chest and then feed that information back into the scanner for triggering or for gating and reconstruction. Another method to compensate and correct for respiratory motion utilize the MRI itself, often called navigators or navigator echoes. These techniques can be inserted into the acquisition sequence and usually excite a small region, usually a pencil-like beam, through an area of interest as indicated by this little diagram here, in order to track signal intensity variations over time. The variations, as shown in this example, can be used to track lung diaphragmatic motion along a spatial axis of interest and to be used for correction of respiratory motion. Like physiologic triggering or gating with respiratory bellows, this feedback about patient breathing can be used to prospectively trigger acquisitions during a predetermined portion of the respiratory cycle, or to gate and retrospectively reconstruct one or more respiratory phases. With some of these techniques that I've described, MRI can be performed reliably for certain indications. And although lung MRI is still not overly clinically utilized, certain jurisdictions are moving faster than others in terms of clinical adoption. Some useful applications and suggestions for clinically useful MRI protocols were outlined in a really great pictorial essay from a few years ago in Pediatric Radiology that describes clinical utility and some indications very, very nicely. In this work by Hirsch et al., they described so-called MR plus pathologies, which cause an accumulation of extra proton density in the lungs, as being particularly well suited for evaluation with T2-weighted MRI. These include inflammation caused accumulation of fluids in the alveolar spaces, infiltrative processes, as well as tissue proliferation, and lung metastases. An example from this work is shown here, showcasing a T2-weighted scan in a pediatric 5-year-old case. This case suffered from pneumonia and significant inflammation in the right lung here, which shows up nicely on this T2-weighted scan, in addition to pleural effusion shown here by these arrowheads. This study also mentioned that so-called MR minus pathologies, that is, pathologies that cause a loss of proton density, such as destruction of lung architecture or emphysematous processes, can be more challenging to detect, obviously, due to the low endogenous proton signal. But this study also highlighted some of the multi-contrast complementarity of MRI. And this included a really, really interesting example of a subject with pneumonia and inflammation, as shown in this T2-weighted scan, that also contained an abscess that is only revealed after a post-contrast T1 or an apparent diffusion coefficient mapping with diffusion-weighted imaging, again, highlighting the flexibility of MRI due to its multi-contrast nature. But what if we want to improve on the low intrinsic signal intensities in the lung? Revisiting this diagram I showed a few slides ago, one potential strategy to improve lung imaging and improve signal intensity detection in the lung is to just shorten the echo time as much as possible in order to capture the quickly decaying signals associated with lung tissues. So-called ultra-short echo time sequences, or UTE MRI, have matured and advanced considerably in the recent decade or so, and can allow for high-resolution structural imaging with density-like weighting utilizing MRI. Typically, ultra-short echo time sequences are performed with non-Cartesian trajectories, such as radial or spiral trajectories, which begin sampling from the center of K-space as soon as possible after a very short RF excitation, thereby minimizing the time it takes before sampling the center of K-space. And on the screen here, I have just a very simplistic pulse sequence diagram of a spiral acquisition, here shown with sinusoidal gradients and the resultant K-space trajectory on the right here. On the screen are some examples of this in practice. These are images acquired with a 3D stack of spirals ultra-short echo scan with respiratory navigation using navigator echoes. acquired in these pediatric subjects during free breathing and reconstructed retrospectively to end expiration. And on the left is a healthy volunteer, a healthy pediatric volunteer, and on the right, a pediatric subject with cystic fibrosis. These were acquired with 1.25 millimeter isotropic resolution and a TE of 0.05 milliseconds, allowing for high resolution investigation of lung structure in these cases. Looking a bit more closely at structural UTE findings that can be detectable in cystic fibrosis. On screen are some examples of CF findings here in these axial UTE scans in a subject that presented to hospital with a pulmonary exacerbation, which it briefly is an acute decline in their respiratory health and function and increase in their CF symptomology, usually the result of a bacterial or fungal infection associated with their inability to clear mucus very well. This subject was admitted to hospital and given a 14-day regimen of intravenous antibiotics treatment. And you can see here with respiratory gated UTE MRI, you can see these radiographic findings, which are these consolidations due to the underlying infection and mucus plugging associated with cystic fibrosis. Furthermore, you can also see and resolve bronchiectasis, which is the abnormal dilatation of these airways, which is a common hallmark in cystic fibrosis. And this is an irreversible pathology that's a result of repeat cycles of infection associated with CF lung disease. And you can see that we can resolve these abnormally dilated airways quite nice with UTE MR in this particular subject. This type of navigated sequence is also amenable for quiescent free breathing in infants and neonates. This, again, are examples using a 3D stack of spirals UTE scan with respiratory navigation, collected in about 5 or so minutes for the examples shown here. The left is a 4-day-old neonate with uncompromised respiratory function, and you can see pretty good image quality and UTE signal in the lung parenchyma here. The right just shows a 4-day-old NICU subject who experienced respiratory distress at birth, requiring some intervention. And so you can see here some atelectasis in the left lung, which is collapsed or non-aerated tissue, which shows up quite nicely using this high-resolution UTE scan. Furthermore, K-space trajectories that sample the center of K-space every excitation, such as this double golden angle 3D radial acquisition, also have an interesting property that may be exploited to improve motion robustness. The center of K-space's magnitude and phase are influenced by breathing, and thus trajectories like this by their very nature, are always sort of passively sampling a respiratory waveform, and these data can be used to retrospectively correct for sources of motion. And on the right is a really good illustrative diagram showing a radial sequence's initial phase of the K0 data point tracked through time in a neonate from a publication from a few years ago. You can see here that these phase data can be used for the correction of both respiratory motion as well as the rejection of data corrupted by bulk patient motion and noncompliance. These large deviations shown here are associated with bulk patient motion. And these lines over here, which they've highlighted in a few different colors, are associated with normal tidal breathing. And if you zoom in on a small portion, as they've done in this bottom panel here, you can see that indeed the K0 phase is sensitive to breathing, and once smoothed in time, the radial spokes associated with their location in the respiratory waveform may be binned according to respiratory state in order to correct for motion. And you can see in this example, the images were reconstructed into 4 respiratory bins they've color-coded here. At our institution, this is a recent acquisition at our institution using the same 3D radial sequence I described earlier in a healthy adolescent volunteer, acquired during free breathing and self-gated with the center of K-space, corrected retrospectively. And in this work, the free breathing data were used to bin the data into approximately 30 respiratory states with an isotropic resolution of 2 millimeters here. This was a very heavily undersampled scan, reconstructed with compressed sensing, but you can see here that the end result is this 4-dimensional spatiotemporal data set that gives a more complete picture of the dynamics during respiration. Acquisitions such as this can be used to evaluate the mechanics of breathing, breathing tidal volumes, as well as lung function. So for the final 5 minutes or so of my talk, I wanted to switch gears and because I thought it might be fun and of interest to this audience to discuss some of the considerations that apply to multinuclear and hyperpolarized media considerations. Why? Well, there is significant intersection of both of these applications in the context of pulmonary MRI in the form of hyperpolarized noble gas imaging, or more specifically, xenon imaging for functional lung ventilation scanning, which we do routinely for research at our institution. So here you can see xenon operates basically as a functional contrast agent that is inhaled to reveal the spatial distribution of the gas within the lungs in order to delineate regions of functional lung from regions of non-functional lung or obstruction in this cystic fibrosis case. And although, of course, this is very niche and very exotic technology, there has been some very, very promising progress towards clinical translation in the last 12 months. Which is why I wanted to discuss this. Around this time last year, close to Christmas, FDA approval for xenon MRI was granted for a broad set of indications for the evaluation of lung ventilation in the United States, down to patients as young as 12 years old. And shortly thereafter, colleagues at Cincinnati Children's Hospital imaged the first clinically ordered xenon scan in North America, incidentally in a 19-year-old cystic fibrosis subject. And so therefore there's significant interest in both radiology and respirology to further develop and utilize this technique as a complement to existing imaging methods, but also methods for functional lung evaluation. Multinuclear applications often require dedicated third-party hardware, however, which requires significant physics and a scientist oversight, which is a potential pitfall. An example here is one of our xenon imaging setups at our institution, showing this, this dedicated birdcage body transmitter and thoracic receiver arrays, both on the bottom and the top. Hopefully you can see that. Additionally, multinuclear applications also require typically dedicated software and or sequence experience. For instance, typical center frequency calibrations, shimming, or transmitter gain adjustments, which are typically performed automatically under the hood by the scanner for conventional proton imaging during the pre-scan portion of a sequence. We take that for granted, and all of this must be performed manually or with custom third-party software for multinuclear applications typically. And in the case of certain X nuclei, such as xenon, with no endogenous source, this means that we have to introduce samples prior to imaging in order to calibrate. And all of these steps can, in principle, if not done correctly, introduce some error negatively affecting scan or image quality, representing a potential pitfall that we have to keep in mind at all times. Furthermore, the very high but non-equilibrium conditions of hyperpolarized media have some additional considerations that are simply just not present when you're talking about thermally polarized MRI. The non-equilibrium magnetization, although enormous, is finite and non-renewable and wants to decay naturally to thermal equilibrium conditions, meaning you have to use your hyperpolarized sample within a predetermined period of time. Furthermore, after application of RF energy in order to tip magnetization into the transverse plane, this magnetization that you've now tipped is irrecoverable. And so in a sense, the imaging experiment consumes magnetization in a manner of speaking. You can see here, this is illustrated in this diagram here in the thermally polarized sample with a low to moderate flip angle. The magnetization eventually reaches, the very well understood steady state shown here due to longitudinal recovery between successive applications of RF energy. However, with hyperpolarized media, you will see that this will basically continue onto zero or to undetectable levels of signal. And so we typically use low flip angles that balance signal to noise, but leave enough hyperpolarized magnetization on the table in reserve in order to cover all of K space. Therefore, you can see that transmitter gain calibration and choice of flip angle is very, very important for hyperpolarized media considerations in protocol development, even more so than typical, because if you are poorly calibrated or you choose the wrong flip angle, you can exhaust your reservoir of magnetization prior to the completion of the imaging experiment, rendering your images undiagnostic or not useful. Besides specific considerations that are inherent to multinuclear and hyperpolarized media, these applications are, of course, also still subject to what I'll call classic MRI artifacts that I wanted to discuss just for fun. For instance, on the screen here is a case where a xenon ventilation scan was corrupted by RF banding or zipper artifact. I've heavily manipulated the contrast here in order to really emphasize this banding. And this is typically caused by spurious RF energy in the magnet room. And normally this could be caused due to the magnet room door not being closed or sealed properly, RF leaks of the room's RF cage, or electronic noise emanating from equipment in the MR room. And in this particular case, after much diagnosing and troubleshooting, it was determined that our MR compatible AV goggles that we use to allow to watch, let children watch Netflix or listen to music or something, while in the scanner, were spitting out spurious RF energy in the 35 megahertz regime, where xenon operates, which necessitated repair. Thankfully, for this particular case, as you can see, the artifact didn't overlap with the lungs too much, still allowing for good quantification of ventilation in this case. And finally, for my last slide, I just wanted to show another issue we recently ran into, where you could see that one slice in this scan, there is the classic K-space or herringbone, K-space spike or herringbone pattern artifact. These are commonly caused by electronic instability or electronic spikes during the signal reception process. Here is an unaffected slice and its associated K-space pattern in the Fourier domain. With the affected slice, you can see spikes at various locations in K-space, and these erroneous data points basically over-accentuate spatial frequency information at these locations in K-space, which translates to these oscillating bands of signal intensities you see in the image domain. It was later determined that some of the electronics in one of our flexible transmit-receive xenon coils had become flaky, and here you can see there's a copper trace in the xenon coil that actually had a complete stress fracture, which likely contributed to the spurious electronic spikes in some of our scans. So with that said, I know that was a whirlwind, but to conclude this brief overview, which is in no way exhaustive or comprehensive, but I hope that I've at least partially convinced you that while still very much a research tool, MRI of the lung has matured in the recent decade or so and offers tremendous flexibility for multi-contrast MRI in children and structural functional complementarity, which is more poised for clinical translation than it ever has been. In conclusion, I'd like to acknowledge all of those who helped with any or all of the studies or works that I've presented here, as well as our sources of funding. And I'd especially like to thank Dr. Giles Santier and Dr. Felix Ratchin, whose sources of funding funded the majority of the works highlighted in this brief talk today. Thank you.
It was very good, excellent and elaborated talk, because this MR lung is something very new concept and it has to be more propagated because of various technical issues and a lot of compatibility issues. So excellent talk. And before winding, just I have a very short question, because we are doing pediatric lung MR. Is there anything like advantage we are having when we are doing the PET MR? Can we have PET? Because sometimes the ventilation scan and perfusion scan, there can be some issues on when you're doing, but still, like, you have a PET, you have MR. Does a PET MR has any advantage?
I would imagine so. I'm not not super involved in PET or MRI myself, but one of the one area of increasing interest is the structure functional complementarity. So understanding the sources of functional deficits we observe with a ventilation weighted scan like xenon, going back to structural MRI. And these processes, like you saw, sometimes on structural MRI, they appear, as radiographic consolidations or hyper or hypo intensities. And there may be an opportunity with PET-MR to, if you have, metastatic, tumorous, or underlying processes associated with metabolic activity that could help, refine this further and understand, the functional consequences of these underlying processes, which would be, I think, really, really interesting. But unfortunately, I have no direct experience myself.
Thank you. Thanks a lot for your excellent session. Now, moving on, I request my co-moderator, Dr. Lisa Suzuki, to take over and introduce the second speaker. Lisa, please.
Hi, everyone. Participating from Brazil, far from Brazil. And I'd like to introduce Erica Pace. She's from the Royal Marsden NHS Foundation Trust from London, UK, and she's going to speak tumor mimics in pediatric body MRI. So please, Erica.
Thank you so much for inviting me. It's a great pleasure to try to share with you my great passion. So I'm a pediatric oncoradiologist, and I was actually thinking the question was asked about PET-MR, because it would be my dream at the end of my career, be able to, to deal more frequently with PET-MR. Having said that, just if you can go to the next slide, please. Just to for you, I don't know if all of you there are confident with pediatric tumors, but just to remind that 1/3 of the tumors are in the brain and spine, and all the rest basically are throughout our body, which means that leukemia lymphoma is the other third, actually 40%, but they can present anywhere, so in any body compartment. And then there are many other types of tumors that are listed here. You can see very small figures, not more than 10%, just to say how complex is the knowledge that the pediatric oncoradiologists and nuclear medicine physician need to have. If we can move forward, please. Thank you. This is just to, it's very interesting how basically from, let's say, one cell type, many of the other tumor types are originated. So basically there are these funny cells which are seen under the microscope, which are called small round blue cells because they appear blue under the microscope. And you can see here list nearly almost the pediatric tumors, and not only, because lymphomas are also present in adults as well. We can move forward, please. So with regards to the tumor mimics, I was focusing on the trunk because this was the title I was assigned to. And if you think of categories, basically there are mainly infections, inflammations, vascular malformation, congenital anomalies, and syndromes, and other benign conditions which basically do not fall in on one of these categories. Move forward, please. So I think that I will start with the upper trunk and moving forward to the lower trunk. So as you are aware, the mediastinum is can be divided into three compartments, and I listed basically in capital letters the proper, let's say, malignant tumors like lymphoma, germ cell tumor in anterior compartment, sarcoma in the middle mediastinum, and neuroblastoma in the posterior mediastinum. And in lowercase, basically the benign conditions, other benign tumors or benign conditions which are not oncological at all. So if we can move forward, please. Okay, so I'm going to show to you an obvious tumor type. You will see in my presentation a mixture of all the modalities, because I think in oncology is key. As you know, I wish obviously in the future we can obviously start with the MR of the chest, but nowadays the CT is still the protagonist with regard to the chest pathology, because it's very easy and all of the centers can do it very quickly. So this is a very obvious abnormal mass, as in anterior mediastinum, is very heterogeneous, it is necrotic, and you can see how And there are also right pleural effusion and some, when there is a little arrow here, some lymphangitic abnormality with the thickening of the interstitium. The vessels are encased, and this is the beauty and the utility of other modalities, because, for instance, in the pleural effusion on the right side, I couldn't really identify the beginning, the nodularity, the pleural deposits, which actually are very nicely highlighted by the PET-CT. So in the future, this could be possible combination, PET-MR rather than CT and PET-CT, so 2 separate exams. So if we can move forward, please. This is another lesion in the same compartment, so anterior mediastinum, but you can see it's completely different. And actually, it was a very interesting story. So this was, by the way, all these cases are from my institution here in London. So this was a 12-year-old boy who did have a car accident. So it was a bike versus a van accident. So basically, there was a fracture. You can see very nicely on the coronal stir, in the corner, some edema in the muscles, and a little bit of cellulitis, because it was a fracture of the main body of the right scapula, and some laceration in the right lower pulmonary lobe. But what was interesting, sometimes might happen what we usually call in radiology incidentaloma, so incidental findings. And basically, this anterior mediastinal lesion was detected. I hope that you can see this tiny calcification, so you might otherwise trust me. So there's a tiny calcification in a normal size thymus. However, the architecture of the thymus is abnormal. And again, this is very interesting, very useful, that each modalities actually give us any useful piece of information, because I would never be able to see this tiny calcification on MR. And but the MR is also useful to see that actually this lesion does have some cystic area, so it's basically a multilocular cystic lesion, and this was consistent with the mature teratoma. Obviously, it is important, as I stated here, the tumor markers were normal. In oncology, is always very important, when we need to review imaging to be able to have information on the tumor markers, because obviously they can guide us. If the tumor marker were abnormal, it wouldn't be not immature, but an immature teratoma, and the measurement is completely different. So again, DR could be either watch and wait if it does not bother the child. I think that we decided in our multidisciplinary team meeting to be resected at some point, because it's 12. So and the idea that at some point it might give some complication in terms of compression or the adjacent structures. If you can move forward, please. This is another entity, thymoma. It is not very common, I have to say, but being a reviewer, there are also some benefits. So when you spend so much time reviewing papers written by others, this was a very nice paper written by a Chinese group, which I reviewed, I think, last year, because this was published this year. And basically, they did an interesting work on collecting all the information, patients with thymoma, so pediatric and adults as well, because it's not a very common tumor. This is a benign tumor, though. Usually does affect people on their 40s or even older. But in our institution, we did have a child. Now here you see how useful is diffusion. I will never stop highlighting the importance and the benefits of diffusion. I do think personally, as an oncological person, expert in imaging, that diffusion to me is even more important than gadolinium sometimes, because at least I can say if there is high cellular or it is not, how it is responding, also to treatment, how the architecture of the lesion is changing or not. Anyway, on diffusion, you can see that this lesion, which is an anterior mediastinum, it is not high cellular, so it is reassuring. And then T2 does help us to see that it is very homogeneous with the regular borders. So what it is, so this group from China did. So basically they try to understand, based on the assessment of T2 diffusion images, they try to understand the different types of thymoma. So basically there are 5 types. And it has been seen that the types which is more necrotic or with a more heterogeneous pattern is then more aggressive. because thymoma per se is a benign condition, but if the architecture is a bit not uniform, it can enlarge, so it can have also mass effect on the adjacent structures that you can think aorta or trachea are there, so there are quite key structures, and so the management is different. If we can move forward, please. Remaining in the same compartment, so this is a very, very rare case. I would say interesting from an imaging point of view, but very sad, I have to say. So this is a 16-year-old male who presented at our center 2 months ago, apparently only with weight loss, some fatigue, headache, so very general symptoms. I was surprised that he did have some dry cough, but didn't have any dyspnea or any kind of overt respiratory symptoms, which was actually surprised me a bit. And you can see they actually there they did have a CT first as a first chest radiograph, which showed an abnormality in the due to the enlargement of the heart and the right lower pleural effusion and passive collapse of the lower lobe, and then the CT, and after the CT they did have an MR. Now it's also here is a teaching point. It is okay. I think it was the right management in terms of imaging. I agree with this approach. However, unfortunately, I was provided, this was done locally in a local hospital, and we review images throughout Commonwealth. So we received this scan. They did the cardiac MR protocol, which was not very useful because obviously I wanted to see, for example, there was no diffusion, there was no contrast, it was just very dynamic sequences, very beautiful, but I couldn't truly understand much more detail of the mass. Usually, first of all, the angiosarcoma, the heart are very, very rare. Usually they do affect adults. And most of the times they arise from the right atrium, as also the rhabdomyoma, which is, the relative benign tumor type. And then tend to grow into the pericardium, as it did happen in this case. I don't have the images because it was done in our hospital together with we collaborate with. And basically, in a pediatric interventional radiologist, he did very, very courageously, very bravely, did the biopsy through a ultrasound guided. And he did tell me, he did show us during our multidisciplinary meeting, actually there was a huge clot within the cardiac atrium. It was a very thickened wall of the atrium. You can see the extensive pleural effusion. So and also on a CT, there are bilateral pulmonary metastases, which is very typical. So from a diagnostic point of view, it is a very straightforward diagnosis, this one, because the characteristics of this mass, which is very rare, and also the typical bilateral millimetric, mainly subpleural lung metastasis. If we can move further, this child is still alive, by the way, and unfortunately decided to have no chemotherapy. It declined. He's 16, he's low mood, and I have to say, obviously, it's a personal decision with his family as well. So he decided not to proceed with treatment for the time being. This is to show to you a same compartment, but a completely benign lesion. As you might know, in oncology, most of the times, if the lesion is either mainly or only fluid, cystic, actually that is reassuring, because very, very rarely a completely, let's say, fluid lesion does have a malignant behavior. In this case, you can see that the lesion is arising from the left anterior mediastinum, and actually the heart itself is normal. There was no contrast. We need to believe here it's a very small image, but there was not enhancement after gadolinium administration. On diffusion, it was completely non-cellular appearances. And this was very homogeneous on T2, and the tumor markers were normal. This child just presented basically with some chest pain and some discomfort and some breathing difficulty. And lactate dehydrogenase was low, because sometimes in lymphomas it is elevated. So it was also reassuring. As I said, this benign condition, it has been seen most on the right side, but actually can be anywhere. And it is due to an anatomical benign congenital anomaly which connect basically due to the fact that all the cirrhosis, so the pleura, in this case, the pericardium, there's been some anomaly in this migration, and so some fluid has accumulated there, forming then a structure with a proper wall. We can just to show, we did a PET-CT because we're an oncological center, so for us it's very easy. And the clinical team was, I was quite reassured by the MR. The MR to me was key. I was very happy. But the clinicians, they insisted for a PET-CT, so we did it. It actually does show some photopenic area there, so no FDG trace accumulation at that site. We can move forward, please. And the other chapter are the vascular malformation. So vascular malformation, there are many types. There have been new classifications, and basically there are alterations affecting all the vessel types, so venous, arterial, and lymphatic. And just to highlight to you, because we obviously, if you're interested in pediatrics, the most common ones that, you know, in a clinical practice you can bump into congenital hemangioma, and those are three types mainly. Can basically either they can involute very rapidly, usually 1 year, 1 year and a half, or remain there, so not evolution at all, or partially evolution, so it might take a while. And then there are high flow, low flow, and obviously it's a collaboration. What is very useful, as you can think of, are chorodoppler interrogation on ultrasound, and some reconstruction or dedicated imaging on MR, like venography or arteriography, or STIR are also key sequences for the lymphatic malformation, for instance. We can move forward, please.
My apologies, I'll share again, and hopefully.
Okay, no worries. Just want to show a few cases that we had with regard to, I think that in the first one might be a lymphatic malformation, lymphangioma, if I'm correct. Okay, that's perfect. Yes. So this 1 year old and 1 month old female presented with this huge lump, and basically she was, when she came to our center, she was 11 months. But this month has been their parents noting this after 1 month from delivery, and gradually has enlarged. It's typical. The typical lateral history of this benign lesion is actually to be very, very big, like a little bit like lapoblastoma, for instance, which are the fatty lesions. And they usually are symptomatic, depends on which body part they are. Usually they are in the subcutaneous tissues, and sometimes if there is an hemorrhagic component, some fluids can be seen. For this reason, obviously, as you can imagine, MR is very useful. I think that actually is the key exam. Obviously, ultrasound is also is the first modality, but because they are quite big, you always want an MR to make sure that they tend not to invade the structure underneath. And so usually there is always a preferred fat plane between this lesion, which do occur in the subcutaneous tissues, and the surrounding other chest wall or wherever they are. They can be located anywhere. Most of them are in the head and neck, but can also be in the limbs. And the treatment is resection, and they can be sometimes misinterpreted, sarcoma or something else. For this reason, it wasn't provided with by the local center with diffusion. I always say that diffusion can be helpful because, you know, if there is any soft tissue component, we can easily identify it with diffusion. If we can move forward, please. Okay, another entity, which is the arteriovenous vascular malformation. In this case, this mass was located in the left groin, as you can see. And usually, if there is an arterial or venous vascular malformation just underneath the skin, you would expect a skin discoloration. And if it is compressible, then it's most likely to be venous. and it can be soft. Sometimes you can also hear some very, very subtle noise, and the can change in size, can become larger or smaller, also depending on which activity or which action the child does. If you think, for instance, it depends where it is located, obviously, but in this case, it could be defecation, or it could be running, so there can be some slightly change in size. And this also was at the beginning, it was not very easy. I was favoring a vascular malformation, but somebody from the clinical team would think, oh, it could be possibly a sarcoma. So at the very beginning, very interestingly, the surgeons took this little girl to theater, and when they started exploring, they were very happy. They could see all the vessels there, so they didn't do any biopsy at all. And actually, they were happy that it was a vascular malformation. As you can see, unfortunately, it's quite big, and it is growing basically both in the musculature, so the external and internal obliques, but also in the iliopsoas, so in the suprapubic area. So it's quite large in in a child who's just 2 years old. So at that time was not resected, but I think that they were planning to do it later on. We can move forward, please. So just to highlight this is that basically even benign conditions, it's very typical, for instance, lipoblastoma, also lymphangioma, as I said, they're usually quite big. So sometimes also benign conditions, even they are not malignant, obviously, they can cause some discomfort or some issues related on the anatomical location because of their size. It's so mass effect, or I would say compression on the structure. This is a very interesting case. So it's very common if some of you, they do some imaging, like for instance, routine ultrasound in a pediatric outpatient list. You always can, maybe I think 80% could be lymph nodes, other neck or other body parts. Anyway, this 12-year-old female, we knew that she had this syndrome, which is the NCAM syndrome, which does comprises some generalized lymphatic dysplasia, this is key, and some developmental delay. Now, because in these children affected by this syndrome, the lymph nodes, also the more than lymph nodes, also the lymphatic channels, vessels are abnormal, basically usually they are either larger or tortuous, serpiginous. Also the lymph nodes can be larger and let's say funny appearances. And this was the case. So basically she did have some an ultrasound for abdominal pain, and also some noctural enuresis, and ultrasound, some enlarged ovoid lymph nodes were seen. Now, I think that the fatty hyaline was still preserved. So when I look at the ultrasound, personally, I was not worried, even though the lymph nodes were enlarged, but they were avoided. You do know very well that in oncology, concerning lymph nodes are spherical, especially if they are so large. That was about 3 centimeters. You would expect an abdominal lymph node being spherical rather than keeping the ovoid shape. The MR was very helpful though, because first of all, it did confirm that the spleen was normal in size with homogeneous architecture, because if it were lymphoma, you would expect an enlarged and also abnormal spleen. But it was very, very helpful to best highlight the preserved fatty hyaline, which I was expecting on ultrasound, which was done by somebody else. So always tricky to interpret somebody else's imaging, ultrasound scans. But it was very helpful to confirm this. So this was a benign condition, and I think that we did follow up this girl. And as far as I remember, she didn't have any lymph node removed. The surgeon said if they were to have further pain, for instance, because they could be basically the larger lymph node is just below the pancreatic tail, we could consider excision of these lymph nodes. And the chest radiograph confirmed a normal mediastino appearances. If we move forward, please. Okay, another entity, always benign entity, is a Casimir disease, much more common in adults or young adults. It's a very complex spectrum. Basically, it is what it is called angiofollicular nodal aplasia, which means that the lymph nodes, basically, a little bit like the syndrome I just shown to you, tend to be larger and tend to be, so the architecture is very, with many mitosis, However, this is a benign condition. Now there are many two types, so it would be so it's a B cell proliferation to start with, and they can be unicentric, which is more frequent and actually even easy to treat because if there is an enlarged lymph node, it is resected, and this does affect children and young adults. The multicentric type instead, there are lymph nodes which most of the times are actually not so much enlarged, but abnormal in terms of appearances. So most of the times are hyperemic, either on ultrasound, CT, or MR, and they can be associated with many symptoms which I listed here. Chest is the most affected compartment, followed by lower trunk and neck. Interestingly, this is a case that we had in our center. This is very atypical because this abnormal pancreatic head was at the beginning with some possible calcification because we were provided with the MR, no other modality at that time apart from the ultrasound, so no CT. So you know that MR is not really the best modality to identify calcifications, but this is what we got from the local hospital. And at the very beginning, I was thinking of something else. I was thinking, for instance, inflammatory conditions like inflammatory myeloblasttic tumor. It could be possibly a central scar. It could be possibly a germinoma, rather than a carcinoma disease. In this case, the abnormal lymph node was within the pancreas, which is also unusual. And it was removed and was proven on biopsy. So, but it did remain the same size for a while because we followed this up. And actually, the diffusion again was I would say, a little doubtful. Sometimes because obviously there is inflammation going on, it can be acellular. So, and because of this, obviously, we decide to do a biopsy rather than watch and wait, even though it remained stable for 8 months. So again, also benign conditions sometimes can be tricky to identify because they can be located anywhere. If you move forward, please. Another very common entity, most of the times misinterpreted lymphoma, is tuberculosis. Now, tuberculosis we know very well is not so common nowadays, but there are still some cases. And we do see here, this was, for instance, an Indian little girl who presented with fever, night sweats, lethargy, and left thoracic pain. Now, if you think of this without any other information, the symptoms typical for a lymphoma are all there because night sweat, fever, lethargy, and they are there. However, when you look at this image, I immediately thought of tuberculosis because you can see that again, we either did a CT rather than MR because of when you have chest pathology, you will start with the CT. And you can see that it was a very necrotic lesion, quite extensive, and there was it was invading the chest wall. Also, some lymphoma that can invade the chest wall, that is true, but it is not so common. And the spleen itself actually was normal size, but it did have some typical small lesion, which obviously you can then confidently call as abscesses. If they were lymphomatous deposits, most of the times they are very hypodense on CT, they are larger, they are very much more heterogeneous. Those are very small abscesses there, and you can see that the bone was a little bit abnormal as well. The liver was a bit enlarged. So overall, I favored tuberculosis, but then we were also assured because the quantiferon was positive. So worst case scenario, obviously, we did suggest to do quantiferon to start with, and we thought if it is normal, then we go ahead with the biopsy. Otherwise, we stop here. Obviously, biopsy also is a bit tricky because it's very necrotic. So we do want to provide the pathologist with the adequate specimen. If we move forward, please. Okay, this is tuberculosis as well, but in the abdominal compartment. Just if you are aware of, there are it can be extensive. You can see some similarity, pleural effusion, and in this case was massive ascites. So when it is affected the peritoneum, there are 3 types. I highlighted here the wet type because this case, a 15-year-old female with abdominal swelling, fever, cough, tachycardia, increased work of breathing, and oxygen requirement in 2 days. So very, very acute symptoms and worsening over a short period of time. There are also other types which are the dry type and the fibrotic type, whereas the appearances are slightly different. So you don't have ascites, or at least it's not a predominant finding. If there is a dry type, you have a kind of much more mesenteric lymphadenopathy, which is not the case. And the fibrotic type, you have much more cake-like omentum and the matted bowel loops. Sometimes it's not so easy to distinguish these three types. It can be much more academic, but this is just to show to you that even though you see such extensive imaging, always put tuberculosis if there are some respiratory symptoms in your differential diagnosis, even though because if it were lymphoma, I would expect a mass somewhere in the bowel loops, like Burkitt lymphoma, which wasn't the case. So the bowel loops here, they were just marked, but I couldn't truly identify a mass, even though there was necrotic lymphadenopathy in the upper respiratory peritoneum. So when there is necrosis, tuberculosis needs always to be, I think, included in the differential diagnosis if there are, let's say, infective symptoms. We can move forward, please. Okay, another entity, this is a focal node hyperplasia of the liver. It's you might know if you are dealing with adult patients, because it's basically a regenerative process, mostly affected the young women. There are some trigger factors like chemotherapy. This was actually the case, and on our child, because it was a child with a medulloblastoma, and she was operated. So the medulloblastoma was treated, and you can see here in the posterior cranial fossa. It was, I think, many years before this, so it was in 2012. And this was to show to you, because it is tricky, how similar are the appearances of this medulloblastoma, which was a desmoplastic type, and the appearances of the lesions in the liver. Now, if you're not familiar with oncology, you can think, oh, there are metastases. Instead, no, she did have chemotherapy, including some drugs containing oxaliplatinum, or kind of with some elements which were in common, and this population, even though this was so young, 14 years old, tend to develop these kind of lesions. Most of the times can be obviously the typical ones with the central scar, which were much more possibly, I think, appreciable in the largest lesion, a small scar, but the small ones, they were satellite lesions, was not really easy to see. Reassuring and very helpful is always a diffusion, because sometimes can highlight them, other times can also show to you that they are not worrisome, and this was the case. So the beginning, in fact, there was a lot of discussion with the clinical team with the biopsy, and then I assured them there is no need, because it's all the factors are there. If this were a 40-year-old female with a colon cancer, it was much easier, much more common. You would not expect in medulloblastoma, but it might happen. So move forward, please.
Erica, sorry for interrupt you.
Yeah.
Just remind you the time for, I'm not sure how many slides you have more.
Yeah, so maybe I'll just do this. There are a couple on the clinic are very interesting, and I will stop if you don't mind. I'll do this one. Okay.
Yes.
Sure.
Yeah, okay. So this one basically is just to remind you, if you're familiar with the pediatric pathology, generally speaking, the Wilms tumor is the most common tumor type, but there are two mimics, this one and the following one, which I want to show to you. They are very rare, extremely rare, but unfortunately, they can create some problems, because in this case, basically below you have basically, so this was a 4-year-old female presenting with apparently facial rash and a palpable spleen. For this reason, she had an ultrasound scan. They highlighted this right homogeneous spherical ovoid lesion arising from the right kidney. First of all, the first difficulty here was to identify the adrenal gland, which is there, but it is very, very compressed by the mass. So the first challenge was to identify the adrenal gland, which was appreciable only on coronal. So coronal are also very useful if you want to see thin structure like the adrenal glands. Furthermore, as you can see, there was a beautiful exam that I received from the local hospital with you can see here, apparently the diffusion is worrisome. because it is restricting, right? And there is some homogeneous announcement there. However, so I thought at the beginning that we were dealing with a Wilms tumor. And this child received 1 month of chemotherapy. And you can see from the bottom, from the top row, there has been no change. So I can assure you there are exams on 2 different dates, 1 month apart. And the chemotherapy that was used was the usual Wilms tumor regime. And obviously, then they went to theater, they was take it out. I think that the biopsy first, sorry, and it was the metanephric adenoma, which is a very rare entity. Usually does affect the elderly, like 50, 60-year-old people, and they can have just, let's say, abdominal pain because of the size, because it is compressed theater structures and hematuria. Now, on what is important, there are specific mutations like CD57 and BRAF positive. So these are very useful for the pathologies and can be associated with the polycythemia. So this is just to highlight you that not always, on imaging, because you might know very well that there are different approaches, European, American, to a biopsy upfront or not. Sometimes, you need to discuss. So I was quite certain it was a Wilms tumor because it was, high cellular vascularized. Actually, then doing some literature research, the key factor here from a radiologist is that the vascularity is lower than surrounding parenchyma. So even though it is high cellular, it's because the cells are quite packed together, but it is not aggressive. If you can show just the last case, the following one, it is another entity very similar, benign entity, very, very rare. Actually, if you look at it, actually even more, apparently more heterogeneous. And again, is a metanephric stromal tumor. So this was a child, 1-year-old with macroscopic hematuria. So in theory, you would think of a potential Wilms tumor. After chemotherapy, after 1 month, this mass didn't change. It was, as I said, some necrosis there. So for this reason, she underwent surgery, so it was removed because you could understand why it was not responding to chemotherapy. It was this benign entity. So again, there are nature sometimes is also cruel. So it is also important to have a multidisciplinary approach to make sure that you do take the right decision. And obviously, we did apologize this case and the prior case as well with the family, because obviously we as a team provide, administer some chemotherapy, but at the very end, they were also even happy they actually, their child underwent the prior case partial nephrectomy. This was nephrectomy because it was a huge mass, but at least there is no risk to have a recurrence. So always, if you are, I would say, honest, is always the right way to go, with the family. So this was, you can go to the last slide, just to make a quick summary. You can skip this if you have no time. Okay. Okay, just to summarize, I think it is very important that we collaborate with the clinical team and we are providing with all the information, like clinical information, if there is a mass, how does it feel, so the physical examination and tumor markers. It is important also have involve and engage with the family, because the family, they do know how the child can collaborate, and if it is compliant or not, if he or she can keep still on the scanner. And in pediatrics, especially in oncology, I would say always start with the key sequence, which to me could be a tissue or it could be a diffusion, and then do acquire the other at the end, because you never know if the child is going to move, especially for when the scans are done on awake children. As I said before, I think that diffusion is key. According to me, should be in every scan that we ask to review. Should not be optional. It's not just in neuro now, it's a standard protocol, but it should be also in adipose part, should be there for us. And if obviously there are some learning difficulties, also best to know as well, because we can try to work with a place specialist or try to shorten the scan if it is necessary. Thank you so very much for your attention. Very happy to take any questions if there are any.
Thank you very much, Erica, for the excellent talk. A lot of difficult cases. but I think we are a little bit behind the schedule. I think we have to move on to the next speaker. So, Skander.
Okay, thank you so much.
Thank you.
Thank you. Yeah, thank you. And,
Okay.
Moving on, we'll move on to our third speaker. Is it Dr. Teresa?
It's me.
Yeah. Yeah. So Dr. Teresa Victoria, she's from MGH Boston, USA, and she'll be talking on pediatric and fetal MRI cases. So welcome you, and over to you, Teresa.
Thank you so very much. Can you see my screen?
Yeah.
Okay, so I'm gonna start, and I'm kind of going to follow a little bit of what the previous conversation was, and we're gonna keep on talking about masses, but we're gonna concentrate on the fetus rather than the soon-to-be ex-fetus. All right, so and we're just gonna concentrate pretty much on the abdomen. So fetal tumors are relatively rare. Usually they're the result of failure of cell differentiation and maturation during the embryonic or fetal life. An accurate diagnosis is fundamental so that we can best counsel the parents, and so we can best take care of them. We're going to talk about abdomen and pelvis today, and we're going to concentrate on hepatic origin, renal tumors, adrenal lesions, and pelvic masses. You're going to see that some of these tumors are going to be very different than the ones that Erica just told us in the session before. So let's go to hepatic origins. So these fetal tumors are about 5% of neoplasms in the fetus and the newborn. They can be solid or cystic. The solid, this is a differential diagnosis: congenital hemangioma, mesenchymohamartomas, hepatoblastomas, and metastases. In reality, the only ones that I have seen during the years that I have practiced is really hemangiomas. The cystic lesions are predominantly choledochal cysts, although you can also have a small liver cyst. And of all these lesions, there's really no prenatal diagnosis, but close follow-up with ultrasound. So let's start talking about congenital hemangiomas, which is really the main hepatic tumor that you're going to see in the fetus. The hepatic hemangiomas, oops, and I'm missing an N over there. They're present at birth, unlike, of course, the infantile hemangiomas. This is it. They can be mixed cystic and solid. They may have calcifications. One of the key findings is that there is abundant blood flow, and you can see this easily in ultrasound. They can be multifocal, and they have a rapid growth in utero. So you always have to have, because of this rapid growth in utero of these solid structures, you have to search for increased cardiac output, which would lead to cardiomegaly, hepatomegaly, skin thickening, placentomegaly, and eventually the development of hydrops, which is a bad prognostic indicator. This is an ultrasound, which is not really, I don't know why it's not really coming out that well, but you can see that there is this large mass, which is predominantly solid. It has some vascular channels over here. It is so large that it was hard to try to figure out where it was coming from. Eventually, we thought that it was coming from the liver. You can see that there is cardiomegaly. The heart is occupying most of the chest, and placentomegaly. This ended up being, this is the ultrasound, the prenatal ultrasound. You can see that there is a lot of vascular flow. And this is a postnatal image of this particular kid. This is the normal liver, and then off of the left hepatic lobe, there was this mass, which was solid with predominant vascular channels. After we gave contrast, the hemangiomas enhanced in this very characteristic fashion: early peripheral enhancement and delayed central filling. This confirmed a hemangioma. And for follow-up, after treatment, you don't have to get subsequent MRs on the kid. You can just follow them up with contrast-enhanced ultrasound of this lesion. The enhancement, this is a gray, white ultrasound, and this is after contrast. The contrast pattern is going to follow what we would expect in MR, which is going to be peripheral enhancement, with delayed central filling. So those are the more common hepatic masses that we find that are solid. Now let's talk about the common cystic hepatic masses. The more common ones are going to be the choledochal cysts. These are the choledochal cysts are focal dilation of the hepatobiliary system. They're called cysts, but they're not truly cysts. They're not self-contained. They're epithelialized structures. And in reality, what they are choledochal malformations of the biliary system. The exact etiology is really unknown, and postnatally, you have to deal with them because they're prone to complications like cholestasis, cholangitis, and pancreatitis. The choledochal cysts, for me, are kind of these fun little entities which have this weird appearance. Most of the choledochal cysts that I have seen are located within the portal. Over here, it looks like, so this is the liver, this is the cystic structure, and it looks like a little tiny flower. So this is the center with these biliary radicals that are acting like the flower. And this is the postnatal appearance of these choledochal cysts with these extensions into the biliary tree. This is a different choledochal cyst. So again, it's kind of arising from the portal area, and it has, in this case, it has two antennas that kind of go into the biliary tree and looks like a cockroach. So these are always very interesting little masses. Okay, so we've talked about the solid and we've talked about the cystic hepatic masses. Let's go and talk about the renal fetal masses. And so the differential diagnosis of the renal fetal masses are going to be different than what we just heard for kids. When you have a fetus with a renal mass, 99.9% of the time, this is going to be a congenital mesoplastic nephroma. There will be the 0.0000001% that will be the Wilms tumor, but I have never really seen it. So most of the time, they're going to be mesoplastic nephromas. So this is, in this case, this is the kidney, and you see this little mass, which is fairly homogeneous. It's iso-intense to the rest of the kidney and without cystic components. So the congenital mesoplastic nephromas is the most common tumor in fetus and neonates less than 1 year. They're non-encapsulated. They may be infiltrated. And polyhydramnios are common findings on a type of these tumors. There are two types of congenital mesoplastic nephroma. The classic, which is this one that you see over here, it's really benign. It's non-aggressive and fairly homogeneous. You take it out and that's it. You're done with this tumor. This is the same tumor seen in TrueFist, and this is in T1. So you can see how fairly homogeneous they are in all sort of sequences. And this was the tumor. This was actually another one that was in the upper pole, but they're fairly similar, kind of homogeneous, and that's the way that they look once they are in the bucket. Now, there are the second type of congenital mesoplastic nephromas, which are the cellular type. And these ones are a little bit nastier. They're more aggressive, more heterogeneous. They have hemorrhage and cystic and necrotic components. And then you have to be very careful with them because they have a higher rate of recurrence. So this is one such mesoplastic nephroma. You can't even see in this case any part of the kidney. You can see this is the bladder. The kid is in distress. There is skin thickening. There is probably a little bit of ascites. So that means that the kid has hydrops. The lungs are markedly decreased because of this very large mass. And the kid also has polyhydramnios. This is a case that it's ancient, but I love this case. It came when I was a resident. You can see that this mesoplastic nephroma has an enlarged heart. This kid has ascites, as you can see over here. And it's really kind of difficult to figure out what is what. But I bring your attention to here. And this green structure is what was the kidney, and this is the distended pelvis. So I'm going to go back so you can see it, and this is a very, very large heterogeneous tumor that had cystic components and necrotic components, and this was a cellular mesoblastic nephroma. This fetus was 20-some weeks of age and ended up dying because of the tumor. This is the actual autopsy. This is the liver. These are loops of bowel. And this is a very large mass, and this is what it looked like once it was open. And as you can see, it's more heterogeneous than the prior one that I showed you. Okay, so we talked about the liver masses, we talked about the renal masses, and now let's talk about the adrenal masses. These are interesting because most of the time they present a diagnostic conundrum. So certainly the most common adrenal mass seen in the perinatal period is going to be a neuroblastoma. But an adrenal hemorrhage, which is a mass mimicker, occurs more often than neuroblastoma. So you have to be able to differentiate these two, right? When you have a parent and they're telling you, okay, so what does my kid have? It's going to be very different to tell them that the kid has a neuroblastoma versus an adrenal hemorrhage. So adrenal hemorrhage, like I said, are going to be the more common ones because adrenal gland is a very vascular organ. And hemorrhage may occur in the setting of stress or as an isolated finding. There are, of course, other lesions that may disguise as adrenal masses, but they're less common. So I'm just going to concentrate on neuroblastoma and adrenal hemorrhage today, just because we have a short period of time. So neuroblastoma is an embryonic tumor of the peripheral sympathetic nervous system. Adrenal origin is about 90% of the cases. So in this case, we have this kidney over here, and there is this suprarenal mass that is kind of displacing the kidney inferiorly. This mass is somewhat homogeneous. It is solid, and it's consistent with a neuroblastoma. Metastases usually to the liver are very, very rare. I never really saw one. We thought that maybe we hallucinated metastases in one case, but I don't think that we really ever saw metastases prenatally. And of course, these type of neuroblastomas are fairly favorable in prognosis. Okay, so what do the neuroblastomas look like? T1 hypo, T2 hyper intense, so of course very non-distinct from other masses. Classifications at this time in the prenatal area are rare, and diffusion weighted images are gonna be your friend, and they're gonna restrict. This is a same tumor. This is prenatally. Usually I have to say that they present in the third trimester, and this is a kid shortly after birth, and you can see a very similar appearance, slightly larger than prenatally. And this is what it looked like in blade and diffusion weighted images. Okay, so how about adrenal hemorrhage? Sometimes adrenal hemorrhage looks very, very, very similar than neuroblastoma. So we have to be able to differentiate them. And so what do we do? Well, the beauty that we have with MR is that we can use all of the sequences in our armamentarium in order to be able to construct a precise differential diagnosis. So in this case, we have, and you can't really see it, but this is the kidney. So again, we have a suprarenal mass. But the interesting thing about this mass is that it has fluid levels, right? So here we go, fluid levels. So a neuroblastoma, it's not really going to have a fluid levels. Yes, it can bleed, but it's unlikely prenatally. So this is more likely to be an adrenal hemorrhage. We can use, and I'm not showing you here, but we can use T1 sequences. And what I would show you is that this area is bright, and that is consistent with blood products. So overall, these are the findings that you would expect in an adrenal hemorrhage. This is a case that we had last week, so I don't have a true diagnosis for you, but I bet you $5 that this is an adrenal hemorrhage. It's very T2 hyperintense. and it has slight debris within the dependent region. Where the fetus was on its back. So it has subtle debris within the dependent region, and I just thought that this was an adrenal hemorrhage. So I will tell you next time that we meet, I will tell you what it is. And there are some other cases. This is another case that came last week. It is actually not from our practice, but from Russia. It's kind of sort of not really a true suprarenal mass, but almost. It's kind of very, it's centered right in the middle, and you can see that it's medial to the adrenal, to the gallbladder. You can see it over here. You can see that it kind of goes medial to the kidney. The kidney is right over here. And then it kind of occupies the center of the abdomen in between, well, anterior to the aorta. And I have a feeling that this is a lymphatic malformation. Unfortunately, I don't have a true, this is a gallbladder. This is a beautiful adrenal. And we start seeing these cystic mass. And this is a cystic mass that kind of insinuates in between the fetus, and this is likely going to be a lymphatic malformation. So this is another of the differentials that we may see. Okay, so let's just move on after we have seen adrenal, renal masses and hepatic masses, and let's just concentrate on to the pelvic masses. And we can have solid masses and we can have cystic masses. The cystic masses, the more common ones are really going to be an ovarian cyst. There are other types of masses that we're going to be able to have, of course, but these are the most common ones. And now for the solid masses, the more common ones are going to be the sacrococcygeal teratoma. So we're going to concentrate on these two and what they look like. The ovarian cyst, the fetal ovarian cysts are the most common abdominal and pelvic masses seen in, of course, female fetuses. And it results because from the fetal ovaries being overstimulated by the placental and the maternal hormones. So this is the first time that the fetus can say it's mom's fault. So this is a fetus, this is a third trimester fetus, this is the bladder, this is a gallbladder, and this is a very large, simple appearance cystic structure with a very thin wall that ended up being an ovarian cyst. They usually present in the third trimester, and the majority regress during pregnancy or after birth. Now, this cyst can be like the one here. It's round, it's anechoic, unilocular. Okay, perfect. This doesn't give us any trouble. They can be unilateral or they can be bilateral, and they can be intra-abdominal versus intrapelvic. So if they're intra-abdominal, don't pull away from being from calling it an ovarian cyst. Now, when we have a little daughter cyst like we have over here, I don't know why this thing is here, but if we have a little daughter cyst, then this is really going to be pathognomonic for an ovarian cyst. So marked by the red is the ovarian cyst, and the red arrow tells us where the ovarian, where the daughter cyst is. Now, sometimes it's very important to note that when these ovarian cysts are complex, then we have to be concerned for torsion. So when can we say that the ovarian cysts are complex? Well, when we have, like we have over here, we have internal components and possibly internal hemorrhage. When we have a thick wall around it, when we have septations, internal debris like here, fluid levels. In these cases, you must tell the MFM that torsion is suspected. Now, it is important to note that torsion, ovarian torsion in utero is not an indication for preterm delivery. And in fact, this baby will be taken care of postnatally. Okay, so those are the most common cystic lesions. And now we're going to end with the solid lesions, which are the sacrococcygeal teratomas. These actually are not only solid, they can be, in fact, solid and cystic components. They can have all sort of mature and immature elements. The thing that I love about these the sacrococcygeal teratomas is that teratoma in Greek comes from the word monstrous, and in fact they can be monstrous tumors. The coccyx is always involved, and so the surgeons always postnatally have to remove it. So in this case, we see this is the fetus, this is the liver, stomach, loops of bowel, and we have this cystic mass, which has an intrapelvic and intra-abdominal component. It extends into a solid mass over here that goes into the coccyx, and you have to be very careful to see if there's intraspinal component or not, and that will certainly tell the MFMs how to deal with the postnatal surgery. Okay. So sacrococcygeal teratomas are described by Altman's classification, with type 1 being mostly external. So these are relatively easy to deal with. This is a cystic component having some solid structures over here, but there is nothing that kind of enters the fetus. And it's really important because if we need to resect this fetus, this is actually very easy to do postnatally, right? So we just have to cut this out and then we're sort of done. I want you to look at this component and I want you to look at it carefully and then tell me what you think this is. Remember that this is a sacrococcygeal teratoma, and the sacrococcygeal teratomas can evolve into anything and everything, okay? I'm gonna count to 2 and then I will move on. 1, 2, all right, hopefully everybody has an idea of what that is. This is a close-up of that area. And now I want you to pay attention to what this is. What is that? And what is that? And what is that? Okay, you're thinking about it. 1, 2, and now I'm going to show you something. This is a kid postnatally. So this is a child, this is a true sacrococcygeal teratoma. And the part that I was showing you is a fetus in feto, which is part of the sacrococcygeal teratoma. You really can find anything and everything as part of these sacrococcygeal teratomas. And this is what was part of this case. Okay, so that was a type 1, which is mostly external. The type 2 is mostly external with a small internal component. So here you see a cystic component that is mostly outside and maybe just a little bit of an internal component. They can be both cystic and solid. Type 3, most of it is going to be internal and it's going to have a small external component. You can see in this case, this is the internal component and this is the external component. And of course, this is, I do have to say that this is a surgical classification that is basically telling the surgeon how easy or difficult it is going to be to resect postnatally. Up here, you can see that the bladder is displaced superiorly by the large tumor. This is still a type 3 tumor. Actually, most of it, it's kind of like a dumbbell appearance. Most of it is going to be solid. Some of it is going to be cystic, and it's going to cause a large amount of ascites and skin thickening. So this fetus is in distress. There is hydrops, and if you don't do anything, then the fetus is going to die in utero. This is the bladder, and you can see how displaced it is. So if you can't remove this tumor, then the kid will die. And this is a type 4 when all of the component is actually going to be outside. So there it is being delineated by the red. There's no component outside, and the bladder over here is going to also be displaced. These are, of course, the ones that are going to be more difficult to resect because it's all inside and there's no external component. So those are the sacrococcygeal teratomas. This is one type of sacrococcygeal teratoma. This is essentially a type 4. You can see that it's a huge, a monstrous tumor, like they were called. in the Greek times. It's predominantly solid. So there's going to be a lot of still vascular flow into this tumor. So this is the vascular flow is going to be stolen from the heart. The heart is going to go into overdrive. There's going to be cardiac failure, cardiomegaly, hepatomegaly, and eventual hydrops with skin thickening, and ascites, as well as a large amount of polyhydramnios. You can see the large amount of skin thickening in this baby. So when you have one of these cases, what you're going to be looking is for fetal decompensation, which can happen very quickly. So these fetuses have to be followed very, very closely, a few times even during the week. So the signs of impending decompensation are rapid changes of tumor growth. So you have to measure these tumors very carefully. Marked changes in cardiac output above 650 milliliters per kilograms per minute, which is a bad prognostic indicator, and of course, adverse Doppler findings. Signs of intratumoral hemorrhage and fetal anemia and placentomegaly are also signs that there is fetal decompensation. And at that point, then you need to think about, delivering the fetus early or doing a partial intrauterine resection of the mass. So this was, in conclusion, a fast tour of the most common abdominopelvic fetal tumors. Pay attention to the location and the gender in order to build a differential diagnosis. Look for signs of fetal distress. Look for signs of hydrops that will tell the maternal fetal person that they need to act quickly and confirm the findings postnatally. Thank you very much, and thank you, Camilo and Mike, for inviting me to give this talk. And I was not on video, but that's okay. You didn't miss anything.
Yeah. Thanks a lot. Excellent presentation, excellent cases, and well explained everything. It was a wonderful session. And thanks a lot. Since, let me check, any questions are there? No, something is there, then we'll share with you. So I request again, Mary, to take over this moderation. Are you there?
Yes.
Yeah, over to
yes.
you.
I'd like to introduce now Alejandra Bedoya. She's from Boston Children's Hospital, and she's going to talk pitfalls in pediatric musculoskeletal MRI. So please, Alejandra.
Thank you so much. Can you see my presentation?
Yes.
Okay, perfect. So thank you so much, Dr. G, Dr. Jaimes, and Marilu for the invitation. We're going to talk about the pitfalls of pediatric MSK. I'm going to only choose two cases, because I think that they show the most common pitfalls, but that I think that PEDS MSK radiologists usually encounter. So the first case, I know the history is long. I am so sorry, but this is a really important history. So this is a 4-year-old male patient that was transferred from another country. This is really important. So most of the images that we had are from outside, and it's unclear where are the radiology reports, what is the radiology, of course, implication in this, but this is what we know. He was transferred to Boston Children's Hospital with the diagnosis of severe juvenile idiopathic arthritis, anemia, and subdural hematoma. So the history is a little bizarre for a 4-year-old. Rheumatology consulted us to review the prior studies. And what we know is that the patient had 1 year of pain, fever, generalized pain everywhere in the hips, ankles, and back. They did a hip MRI that I'm going to show you. And based on that, they started prednisone and methotrexate. Then the patient developed papilledema, a CT brain was done, and then 6 months later, he developed forehead nodules, and a CT brain was done, and neurosurgery was consulted in his home country. So these are the initial radiographs that were performed 1 year before the patient came to us. And as you can see, normal pelvic radiographs in a 4-year-old. Then we have the outside MRI. So this was done again 1 year before. And I want you to really look at these images. So we have a coronal T1 image here. We have 2 coronal T2 fat sat images in different slides. And I want you to really look at this because based on the history, they started methotrexate and prednisone based on these MRI images. So we for sure see some, maybe a small left greater than right, hip effusions, maybe some abnormal signal here with muscle signal, periarticular edema. So based on this, they started that. But the topic of this talk is pitfalls. So I'm going to show you the real diagnosis at the end. They also did knee ultrasounds, and here I'm showing you, so this is the right and that's the left, and just to localize, we are in a sagittal, longitudinal view of this is the patellar tendon anteriorly. Unfortunately, this was interpreted as bilateral knee effusions, and as you can see, something was measured here in the ultrasound. But when we really look at these images and we try to first know where we are. So when we need to identify where we are, this is the patellar tendon. So that means that the patella is here superiorly. We can here see the femoral epiphysis, the distal femoral epiphysis that corresponds to this area. Then we see the tibial epiphysis, the physis, and the metaphysis. So the truth is that what it was measured outside was actually the epiphyseal cartilage that is pretty anechoic in ultrasound. So we have this patient with potentially bilateral hip effusions, potentially bilateral knee effusions, and that's why it was suggestive of JIA. But we need to remember that this epiphyseal cartilage is pretty prominent, pretty large in skeletal immature patients, particularly 4 years of age, as we can see in the correlation of an MRI in a patient of a similar age. And we should avoid to interpret these as joint effusions, as we can do dynamic maneuvers to really evaluate if there is fluid that is moving and not the normal epiphyseal cartilage. These are the CT heads, the CT brains that this patient had. One in September 2019, the other one in June 2020. And unfortunately, this is the CT that was potentially interpreted as subdural hemorrhages, because there are these subdural, what it looked like hyperdense collections. However, they are not collections. If you see, there are these anterior nodules that are extra osseous, and subdural collections will not act this way. Unfortunately, in this case, the model appearance of the bones, this heterogeneous appearance of the inner bone as well as the outer bone was not visualized. And these are actually extraosseous soft tissue solid masses and not fluid collections. So this is unfortunately how the patient presented to us 1 year after the initial MRI. And we can see now that the radiographs of the pelvis are completely abnormal. There are all these mixed lytic and lucent areas throughout the pelvis in the proximal femoral heads. We can even see that there are some changes of avascular necrosis involving the bilateral proximal femurs, bilateral proximal humeri, and we can see these abnormal masses in the left pelvic region as well as the supraclavicular region, and this patient unfortunately had more masses throughout the lung. So when we had this, we talked to rheumatology and we said, okay, this is not juvenile idiopathic arthritis. This is more concerning for metastatic lesions. So this patient turned out to be a neuroblastoma with extensive diffuse metastatic lesions. And this is the MIBG study that we perform. And even this MIBG study, I think, is one of the highest scores we have had, is 29/30. And it does look like a bone scan. So this was extensive metastatic disease. So the question is, how can we avoid the delay of this diagnosis and treatment in 1 year? And that's what we're going to talk today about the normal bone marrow changes. So neuroblastoma is responsible for 15% of the cancer-related childhood deaths. It's usually in patients younger than 4 years of age, we can see that lymphoproliferative disorders and CNS tumors are more prevalent, but neuroblastoma is always there in the differential. So to understand the abnormal appearance of the bone marrow, we first need to understand what normal looks like. And this is where the histology of the bone marrow is really important. So we have the red marrow, which importantly, it has 40% fat. Yes, it has more water, it has more cells, but the important thing is that it has 40% fat. And the reason why I say this, that this is important, is because MRI is highly sensitive for fat and water. So we're trying to identify that 40% fat in the images that I'm going to show you. Then we have the yellow marrow, that it has 80% fat, less water, and of course, less cellularity. And there is a normal process of transformation of the red marrow into the yellow marrow. So this is called bone marrow conversion. And the important thing is that it has a pretty determined pattern of bone marrow conversion. So the first thing is that if you take into account the whole body, you first are going to convert your distal bones and then your proximal bones. That's why in the axial skeleton, like in the spine, we can still see a lot of red marrow, particularly in women that have a relatively degree of anemia compared to the men. But what you can see is that the axial skeleton is going to be the latest to actually convert. But something importantly is that within each bone, there is a focal, predictable pattern of conversion. And this we really need to know in pediatric imaging. So the first thing that converts to red marrow, from red marrow to yellow marrow, are the epiphyses. And the epiphyses, of course, first is going to be the distal epiphysis and then the proximal one. Then it's going to be the diaphysis and then the metaphysis. So I don't know if you can see me in the video, but I always do to my fellows and my residents: epiphysis, diaphysis, metaphysis, epiphysis, diaphysis, metaphysis. And that's a normal bone pattern reconversion. Something important also another rule that we need to remember is that the epiphysis, initially when you see the epiphysis on radiographs, is going to be red marrow. And it's going to be red marrow for 6 months after the radiographic appearance, and then it's going to turn into yellow marrow. So I know that each bone has a different, time where the secondary ossification centers appear radiographically. But if you know that some of them appear at a specific age, you know that in 6 months, it should be yellow marrow. So this is just examples of the T1 weighted images changes throughout the life. So the T1 weighted images are the most important ones to evaluate bone marrow. This is extremely important. So T2 is really good for identify lesions, but if we really want to characterize if something in the bone marrow is normal or abnormal, we need to go to the T1 weighted images. So at the first week of age, almost everything is red marrow. The evaluation of the red marrow is extremely difficult at this age. But as the patient gets older, you can see the changes, and you can start seeing yellow marrow in the epiphysis, then metaphysis, and then the diaphysis, and the latest one are the ep and the metaphysis, particularly of the proximal bones. This is a fetal MRI, a T1 weighted image, and you can see how the bone marrow is extremely darker than the muscle. It's a highly hematopoietic bone marrow, really dark. There is not that much fat because of the activity that is happening during this time. So the important thing of MRI is actually the signal. So it's first a distribution, of course, as I just explained, and then the signal. So the T1, and this is the most important thing if you're going to remember anything from this conference, is that if you have a normal yellow marrow, that signal has to be higher than the adjacent muscle. So it has to have the normal distribution, right? Particularly metaphysis, and then it has to be higher in signal. You can use the muscle as your control, and in the spine, you can use the intervertebral body. This the red marrow can enhance, so that's why it's not as useful, but this is the most important thing, and the reason why it's higher is because we have 40% fat. Chemical shift is a really important sequence in adult imaging. We know that it's a GRE sequence, it's an echo gradient sequence, that it shows the resonance difference of water and fat. And if you have microscopic fat, you're going to have loss of signal in the out of phase imaging, because they are going to they're going to interact with each other and then going to have a negative number if there is water and fat in the same voxel. However, it's not that useful in little kids. In pediatric imaging, the truth is that we don't use it as much because, as I said, in this neonate, you can see how this bone marrow is so active, so hematopoietic, that even in the out of phase is lower signal than the in phase. And the truth is that we don't have the chemical shift imaging as part of our pediatric protocols. So the bone marrow abnormalities can be an abnormal signal, as we said, like the first thing that an aggressive lesion is going to do is get rid of the fat. So you're going to have really low T1 signal, and of course, a normal distribution of the red marrow. So if we go back to our first case, the first imaging, I think we can see now strikingly how abnormal the bone marrow signal is. So the T2, it's so abnormal that it's really hard to identify the abnormality. But if we really pay attention to the proximal epiphysis of the femur, we know that this proximal epiphysis will appear approximately at 3-6 months of age, because that's the time, 3-6 months of age, because that's the time that we do ultrasounds to evaluate for hip dysplasia. After that, we do hip radiographs. So we know that approximately at 1 year of age, right, you are gonna have yellow marrow in your proximal epiphysis. In this case, it's extremely low signal, so there is abnormal distribution, and also the signal here is actually lower than the adjacent muscle. So this could have been preventable, this delay in diagnosis, but the problem, and I call it a pitfall, is because sometimes when the bone marrow signal is so abnormal, diffusely abnormal, it's really easy to miss, and that's what I'm showing in this case. This is a companion case that actually came 2 weeks ago to Boston Children's. It's a 4-year-old with ankle swelling and pain for 2 months. The radiograph, the bone density look normal overall, no fractures, but we can see this pretty large joint effusion. So we weren't sure exactly what this patient had, maybe some Lyme disease, which is really common in our institution, or septic arthritis. We're not sure, but the history was 2 months of pain, so we were unsure. We performed an MRI and we confirmed that there is a large tibiotalar joint effusion. This is the sagittal T2 fat sequence. This is the sagittal T1. And at the initial visualization of these images, it doesn't look as bad, the bone marrow. But then if we really apply what we just have learned about the distribution and the signal, we can just, for example, focus in this distal tibial epiphysis, and we can see that at 4 years of age, it's really atypical to have what it looks like red marrow or low signal in your epiphysis. And then as we keep looking, because the distal epiphysis secondary ossification center appears in the neonatal period or in the fetal period. So that means that at 4 years of age, this has to be yellow marrow. However, is lower in signal, is not yellow marrow. And there are some areas that look actually darker than the adjacent muscle. And these, we were really concerned for a bone marrow problem, and they performed a bone marrow biopsy, and it was lymphoblastic leukemia. So it was new diagnosis that only a MRI and us were able to help with. So the last case I want to show is an 18-year-old with persistent pain in the left knee. So these are the radiographs. We have a lateral and a frontal view of the knee, and we don't see any joint effusion. Actually, these were interpreted as normal prospectively. Then we have an MRI, and there is a striking abnormality of the proximal tibial epiphysis and metaphysis. So there is this ill-defined abnormal T1 signal that doesn't look aggressive because it's really hard to delineate, which is the opposite than radiographs. But if we have on T1, this looks more like bone marrow edema, right? So there is this low signal, this really high signal on T2 with a periarticular soft tissue edema and muscle edema. Then we gave some contrast, and all these bone marrow edema and periarticular changes were enhancing. So at this time, and I want you to really look at these images. There is, as I said, this is a pitfall, but it shows the finding of the final diagnosis. But at this time, prospectively, we were unsure about what this was. So we were like, can this be osteomyelitis? Can it be CRMO? Can it be like primary lymphoma, which primary lymphoma was a little less in the differential diagnosis because of these non-aggressive bone marrow changes. So osteomyelitis was ruled out based on clinical information and inflammatory markers. So CRMO was still in the differential. So we actually performed a whole body MRI that didn't show any additional lesions. So it was not consistent with chronic recurrent multifocal osteomyelitis. So we went back and we said, okay, let's go back, take a look at these images. We actually reviewed this case in tumor board. And something that we can see on a single image, and is this coronal T1 post-contrast, is this area that is pretty round. And as you can see, all the inflammatory changes are centered there. So we said, okay, can this be an interarticular osteosteoma? And just looking at the images retrospectively, we can see this single slide when it shows the finding. Actually, we recommended a CT that shows the osteosteoma with the partially calcified intraluminal focus and adjacent periosteal thickening, and this was confirmed with an interarticular osteosteoma. So I believe this is the second pitfall that MSK pediatric radiologists encounter. These interarticular osteostomas are really hard to diagnose. Actually, there are some cases of adolescents of pediatric patients with a lot of pain, delayed diagnosis between 1 and 3 years. And some of these patients, because of the severe pain and the atypical presentation, there have been case reports of unnecessary surgeries, also cases of depression and suicide related to this interarticular osteostoma. So we really need to think about this and have it in our differential. So when I talk about interarticular osteostomas, and when I talk about osteostomas, we always try to think about the classic extraarticular one, which is the one that has, the cortical base, usually, the internal nidus with the calcification and extensive cortical thickening and periosteal new bone formation. However, the interarticular osteostoma is not going to show the same findings. So usually the radiographs, there is no periosteal reaction, there is no periosteal thickening, and the cases that have an interarticular lesion that is intrasynovial is going to have this extensive synovitis and joint effusions, this geographic bone marrow edema, that the truth is that is really hard to see on MRI. CT is more useful to identify the nidus, but we have seen cases where it's also challenging. So all these are examples of confirmed interarticular osteostomas. And the truth is that prospectively, it's really hard to see them, right? It's not the classic osteostoma. And some people say that if you really pay attention, you can see the subtle lucencies and the subtle periosteal new bone formation. But if it's truly interarticular, it doesn't have periosteum. So I'm going to show here in the arrows where these lesions are, and they're really hard to see prospectively, right? Then when we go to the MRIs, all these cases have proven interarticular osteostomas. And the problem with these interarticular osteostomas also is that some of the time they start with an MR because the clinical presentation is actually atypical too, because of the degree of synovitis, the degree of joint effusion. Actually, they can present with symptoms that look like inflammatory arthritis. So they have joint contractions and soft tissue edema. So they can be really tricky. And sometimes radiologists are the first one to actually suggest this diagnosis. All these cases have the joint effusion, geographic bone marrow edema-like changes that is persistent in multiple examinations, particularly if you don't get with the diagnosis on the initial one. CT is still the gold standard, the same as the extraarticular counterpart. But the difference is that sometimes, and this is when things get tricky also, is that the nidus can be so small, particularly less than 5 millimeters, and it may not have a calcified nidus. And these are the cases where it's extremely challenging on CT. And these are the cases where we think actually nuclear medicine scans play a vital role in confirming the diagnosis, particularly for surgical planning. So we can do a bone scintigraphy with a SPECT. It's helpful to actually make the diagnosis as the focal intense uptake, but it's not as helpful for a surgical planning to evaluate the relationship of the nidus with the articular surface. In that case, we use sodium fluoride PET-CT because it has higher spatial resolution, although it has higher radiation, but sometimes it's really important for the surgeon to identify and to plan how far you are from the articular cartilage, or either if it's too risky, sometimes they actually let these lesions resolve on their own, which can take between 2 and 11 years. So in summary, MRI plays a vital role in the assessment of bone marrow in children. The patterns that deviate from normal bone marrow conversion should raise the possibility of pathology. And the presentation of interarticular osteostomas is different than the extraarticular ones. And we need to look for effusion, synovial thickening, and enhancing bone marrow edema, and MRI plays an important role here too. Thank you so much.
Thank you, Alejandra. It's astonishing cases and scary cases, right? But yes, but I'm not sure if we have time to ask Camilo. Send me a message that we have less than like 1 minute to zoom down. I don't know. I'm not sure. So Alejandra, the tip is you have to have your chart, conversion chart by your side to not to miss the lesion, right?
Yes, for the bone marrow?
Yes.
Yes, I think it's always, those are the things that we miss the most because it's so diffusely abnormal that we don't pay attention to that. Yes.
Okay. Yes, I think there is no question for the audience, and I'm not sure we are going to close. Moby, Camilo?
Camila has already left, but yes, we are wrapping up. Thank you everyone for your presentation and for attending. Again, this will be recorded and it will be posted. This is recorded and it will be posted on our website within 24 to 48 hours. Thank you, guys.
Thank you.
Thank you,
Bye.
Thank you.
Bye-bye.
Bye.
Thank you, Alexandra. Bye-bye.